Hi, everyone, and welcome to this episode of the Good Death Virtual Book Tour. And we have a good death movement that is in full swing. And when I say good death movement globally that's in full swing, I want you to know that that means we have a good life movement in full swing. And it is so exciting to see this community grow, to see us flourish and come together in this thing called humanity. So today, in our episode of the Good Death podcast, we are continuing on with our virtual Good Death book tour, and we are going to talk with Jennifer O'Brien. And Jennifer O'Brien is the author of The Hospice Doctor's Widow, a journal that was a beautiful art journal that she did. And she also is the author of Care Boss. And we are going to talk today about moral injury and what healthcare professionals are seeing and suffering from, in addition to all of the challenges that they have. There's something called moral injury, and I know I have suffered from it myself, and it still haunts me to this day, the things that I have seen and witnessed within mainstream healthcare. Should never be that way. There's no judgment here, but we want to be really clear on what we need to do to change this. So this is a very deep discussion, and I want to remind you that we have a Good Death movement and a Good Death book club that is live, a death and dying course that is every month in global community. They are amazing. So if you have not joined that yet, you want to join with the link below. We are here showing up to change the world, and how we do that is doing it together. All right, everyone. So sit back, relax, enjoy this episode of the Good Death podcast. Jennifer, welcome to the podcast.
Thank you so much.
I'm glad to have this conversation with you always. But I think as we move in the evolution of the movement, it's going so quickly that it's great to be at this part of the juncture and to really shine a spotlight on where we both think we are now and where we need to make changes to go forward in humanity for this space. So before we jump into that, could you just give a little bit of your background, please, and how you found yourself called to this space and this work?
Yeah, I'd love to. So I've been in the healthcare space for almost 38 years now, mostly on the administrative leadership side of things. I lost my only sibling when I was 18. My mother died not quite 20 years later of pancreatic cancer. And then in that work in healthcare, I did some interim leadership, which led me down to Little Rock, Arkansas, where I met my beloved Bob Lemberg, who was a hospice and palliative care physician. We fell madly in love and got married. And then he was diagnosed with stage 4 renal clear cell carcinoma that was already metastatic throughout his body. And he lived for 22 months. And of course, we were turning his professional experience and my personal experience kind of in on ourselves, right? As we did that. While he was ill, I kept an art journal. After he died, I returned to interim leadership in healthcare and was working in a practice, and a neurologist looked at my journal and said, "You got to figure out how to get this published because it would help a lot of people." And I just was really compelled to do that. So I did that. 5 years ago, it was published as The Hospice Doctor's Widow. And I love the space. I mean, this is, in my opinion, the best corner of healthcare. It really is. And so I've gone on and wrote a second book called Care Boss, where I've taken all that leadership experience and gifted it to family caregivers to say, you're a leader. So here's some help in how to really be the leader that a family caregiver is. And that came out a few months ago. And like I say, I just continue to love working in this space. The authenticity is unbeatable, right? Like there's no greater truth. So
Does
yeah,
not get more real than this.
no, it does not.
And also you're at the threshold. There's so many beautiful things about it, being invited into families' experiences at one of the, if not the most vulnerable time that they have. What an honor that is, but really getting a glimpse at the veil within this space. And it does not get more real, not just about death, but about life. So let's, if we may, I don't think there's ever an accident with anything. And so when you yourself, you have the administration background, but when you yourself found yourself as a caregiver to somebody who loved deeply, who was a hospice doctor, so you all have that inside information. What was that like being a caregiver? And did you find what was really missing as support and education in that space?
Okay, so what it was like um, is both the hardest job I've ever done and the most important one I've ever done. And I mean, just undeniably, it is excruciating. It is not for the faint of heart, and it's the most important thing I've ever done.
And can we stop there for 1 minute? Because I think that all of us are going to be called to show up for people we love at the end of life. And knowing how to do that change because we want to, right? So I think like I just want to plant that seed for people because it's the lack of awareness of end of life being even a part of the journey and the support from the main system and then the skills that were handed down generationally are lost. So I love that you shared that it is difficult, it's excruciating, but it's also the most important and rewarding thing that we show up and knowing how to do that can change everything. Yeah.
Right. And within that trajectory of family caregiving, part of the reason I think it's hard, especially at end of life, besides the fact that you're losing this person that you absolutely adore, is so the average duration of family caregiving is 4.5 years. It's the average. So sometimes it's going on, right, for a decade or more. And you are throughout that time a life-sustaining family caregiver, right? So things like hydration and getting a good meal and a good night's sleep and, blood sugar and pulse ox and all that sort of stuff, super important every single day. And there are two transitions that a family caregiver faces. The first one is transitioning from life-sustaining family caregiving, which I just described, to end-of-life family caregiving. So 4.5 years, and then hospice, the average length of stay is 91 days. If it's cancer, it's 19 days. So, right, for 4.5 years on average, I've been this life-sustaining family caregiver.
Mhm.
And then suddenly, sometimes within days, I have to transition to end of life family caregiver, which is totally different, right? Which is
Mhm.
not
Mhm.
about hydration. It's about letting the body shut down naturally. It's about being present with my love and my care more than checking vitals. And, it's about letting him sleep and just being present, as my late husband would call it, precious time, just being present in the precious time. That is an extremely difficult paradigm shift to make. When the hospice nurse comes and does the admission, he or she understandably focuses entirely on the patient almost. And I, who am making this really difficult transition, am kind of a bit of an afterthought, not in a negative way. I'm not meaning that to be ugly in any way, but I'm not the primary focus, and yet I am the one making this big difficult transition. The second really difficult transition that the family caregiver makes is from being family caregiver to griever, right? And that's what that end of life caregiver, transition leads to, which adds this unbelievable layer of emotion, right? To the transition. So
Mhm.
yeah, it's big and it's important. And I talk about what I call the triad of certainty, which is at the end of life comes death. There are no do-overs in end of life and changed forever. The loved ones remain and remember. This will affect the family caregiving giver for the rest of their lives, right? And they will either have regret about not successfully making that transition and thinking they had more time with their person, or, just in my case with my husband, we did all that preparation. We knew what was coming. And so I
Mm.
just had to love him and miss him and grieve him, which is not easy, but it is easier to do all that when you have faced what's coming.
Okay, so let's stop for a minute if we can and focus on, no, there's lots of great stuff there, is the 19 days. Because if we, so two of the things that I'm hearing you say, which are really important, is that if I pretend that this isn't going to show up for my loved one, 100%, if anyone knows any different, but I have to tell you, I've been doing this a very long time, that 100% that it has shown up at some point.
Goes up. Yep.
When we pretend it won't, and it's not going to, when it does, it is extremely difficult. Now, you mentioned 19 days with cancer, people on hospice, 19 days.
Nothing.
That is a little over 2 weeks. As a hospice, a former hospice nurse, I was there for 1 hour once a day if my patient was what you call stable. There's other support that can come in. I'm supposed to teach the loved ones how to do this care. They're in shock. They don't even know what's happening. They're
They
trying
don't
to
know what
deal.
hospice is sometimes.
Sometimes they know usually they know the word and they know that it means end of life support, but they don't know what they do and what they don't do. And the time to find that out is not when you're with them, when you need them.
Exactly. Exactly.
So there's two things that you've outlined. One is this caregiver crisis that we have in general, right? Because we have longevity of lifespans like we've never seen before in history, ever. And what happens when you haven't seen something before? You don't have the setup for it. But also, the very sobering reality is the longer that we live, usually, there may be cognitive problems, physical problems, financial problems, all of the above. And we have seen people live for decades in this challenged state, not at the end of life yet, but in this caregiving state. And it's just a crisis and it's not working. So that's one space. And then, of course, you've got the end of life, which we're pretending doesn't happen, so that when it does show up, that's not going well either. What do
Yeah.
you say to that?
Well, I think well, first I say absolutely. You've hit the nail on the head, no question. Not only are we living longer, but we've got this baby boomer generation that is the largest to first
Mhm.
live that long. And I think one of the things that's not happening in our society is the difference between lifespan and health span, right?
Or quality of life?
Yeah.
Yeah.
The
Yeah.
fact that we're living longer, um, but as you point out, that the duration of that care needing, caregiving stage is growing.
Yeah.
Another thing I think that we'll just spend a second on is your choice of the word pretending. I'd like to give us all a little break on that, in that we're all doing that. Even the authorities in this space, not in this space, but in the healthcare space, are doing that, right? Like the doctors refuse to
Yeah.
talk about it. The nurses
Yeah.
refuse to talk about it. We have questions. We know that at the end of life comes death. We know that it doesn't seem to be getting any better, but nobody really wants to sit down and say, what does it look like for you? What does a really good death look like for you? Um, I've recently I spend my summers here in Santa Fe, New Mexico, and I spend the holidays in Santa Fe. And so at the end of Christmas time, or right around Christmas time last year, was when Gene Hackman was found dead. And then recently in Santa Fe, we had a senior whose family did not realize how far along her dementia was. She wandered off
Mhm.
and still has not been found, and it's been 3 weeks. And so I,
Yeah.
I know this is
Yeah.
this might be a little controversial, but based on the name of your book, I think it's worth, if you're having trouble
Yeah.
exploring or aiming for what you consider a good death, then why don't you start with a couple of bad ones, right? I think that Gene Hackman, that's a bad death. I mean, that's something none of us want to happen. So you could start at either end, but if you're having trouble envisioning good, then start with bad and outline what you didn't like about it, and go to what you would want for yourself or your loved ones.
Well, there's no lack of examples there, unfortunately,
I
because I
know.
mean, I have and this is what prompted whole Doula Givers Institute is over and over and over again, end of life not going well, or as well as it could go.
Right.
Why? Why is this happening? Even in the space of hospice care. And so it baffled my mind. And so
Yes.
part of that is what you just said a minute ago is about our healthcare system and our doctors and the lack of awareness. So because that's your background, healthcare, and I'll give you my experience as well. Can we talk about the advances, which is a wonderful thing that have been made, but at the same time, have we removed any of the education, support, and even allowing doctors to know how to support people in this very, if not the most important part of the care that they give, is to support that person with symptom management and comfort and presence and their family. And it's absent now.
Yeah. 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 I love our healthcare system. I know you do too. We've both spent our lives working in it, but I think it's got some fractures at this point. And perhaps in my mind, the biggest one, is this notion of making death the enemy,
Hmm.
right?
Hmm.
Now, that's a problem, right? Because if your enemy is inevitable, right,
Hmm.
then you lose to your enemy with every single patient eventually. So why on earth would you make it your enemy?
Who made it the enemy? How did that happen? I mean,
I
I'm
think
just, I'm
we
just
got
kind of,
in, yeah, we got into language like the war on cancer, which might be okay in a global sense to call it a war, but it ends up turning into an individual battle, lost his
I don't
battle
think,
with
I don't think it is
leukemia.
okay. Yeah.
Right. So
Yeah.
it has become this war and competition and sports language
Mhm.
as it relates to the most essential and beautiful and potentially sad and
Mhm.
life affecting
And natural.
reality of death is a big mistake. It's a big
It's a
mistake.
huge mistake. And so, right. And so I agree with you. So I feel like on socially within the medical system, I think we've inadvertently created this war with something that's impossible to win. It's not a war anyway. And in doing so, we don't talk about it. We don't plan for it. We don't educate. We don't know the beauty of it. We don't know the choices that we have. And we treat doctors like they failed if their patient dies. So they feel compelled to do this, to do this, to do this. And we know as medical professionals how to keep people alive, but keeping people alive and living are two
Yeah,
very different things.
yeah. Keeping someone
Mhm.
breathing,
Yeah.
right, is
And their
not
heart beating. Yeah.
necessarily keeping them alive.
Yes, that's exactly right. That goes back to quality of life, which I cannot emphasize enough. Let's talk about, if we can, because I know we've discussed this. There is, we are educators in this space, and there is so much confusion about the term hospice and palliative care, because a
Right.
lot of times they're grouped together and they're two very different things.
Right, right. So first off, any specialty that involves two different terms, obstetrics and gynecology, hematology and oncology, right? If there are two terms, they are not redundant. They
Hmm.
mean
Hmm.
two different things. So it's called hospice and palliative care, or palliative care and hospice. They are two different things, right? And what's happening is a lot of healthcare professionals, quite frankly, I think they're synonymous, and they are absolutely not synonymous. They do have similarities. They do
Hmm.
have similarities. They are both interdisciplinary teams. They both include lowercase p palliation, right? They both include comfort and the easing of
Hmm.
suffering.
Symptom management. Yeah.
Yep,
Hmm.
and symptom management. But in hospice specifically, it's a life expectancy of 6 months or less, That is not the case in palliative care. You can receive curative treatments while you're on palliative care. You can receive life-extending treatments while you're on palliative care. I always love to tell this story about a patient, a palliative care patient of Bob's. She was very, very sick when, at about the time Bob had to stop working because of his own illness.
Mhm.
She got her third kidney and of her life. And Bob visited her 3 days post-op on his last day of work. I
Mhm.
know. And you know, she has long outlived him, right? None of his
Mhm.
hospice patients have outlived him, but
Mhm.
many of his palliative care patients have long outlived him.
So I feel like this, Jennifer, I think because of the fear surrounding death and people know that hospice means end of life, I think anywhere that something's attached to that at all, it gets shut down. So maybe, and we've talked about this, maybe in the origin of hospice when it was starting, palliative care is a component of symptom management for the highest quality. But because many things have been labeled together, I think it has brought, unfortunately, a misunderstanding of what palliative care is now when you join 2025 and people are living longer than they ever have. Palliative care is so necessary for this moment and moving into the future so that, again, people can have tight symptom management for the highest quality of every day for as many days as they have. And from what I'm hearing, they're going to have a lot. So we have this, and even medical professionals don't understand it. They say, oh, palliative care, you're not ready for end of life. Hold on, wait a minute.
Right, not the same thing.
Not the
Yep.
same thing. So what do we do here?
I would also point out another difference between the two is hospice is a status, right? It's more than just a specialty. It's a status for the patient, whether the patient's at home or in a facility, in a hospital, sometimes as a hospice patient. Um, Palliative care is just like every other specialty, obstetrics,
Yeah.
neurology. It is
Yeah.
not a status. It's a subspecialty of care.
Yeah. And
I think
I
that's
think
another, that's another thing that kind of gets blurred.
I like that. I really that I like that clarity. I think palliative care should be part of all care almost
Yes,
because
I agree.
yeah,
I
just
always
because
say palliative care, go early, go often,
and it's also really about always focusing on quality of life. And for me as a medical practitioner, and we know this, the system is fragmented. There's very little time with patients, which your time gives you the ability to diagnose and to really get to the root. I was just doing the Good Death Book Club experience and we were talking about pain. And we were talking about nerve pain. I remember sharing the story with them that I had a patient. She was 80 years old, diagnosis lung cancer on hospice care, came in and she said she described her pain as an 8 out of 10, an 8, 9 out of 10. She was on high levels of morphine. Her pain was in her head. And I was like, wait a minute, this isn't adding up. Digging deeper, asking her to describe the pain, and then realizing months earlier she was hospitalized for shingles. This was nerve pain. And when we were able to define that it was nerve pain, I could get her a prescription from the doctor for nerve medicine. Her pain went all the way down. She was off the more quality of life went up. That's palliative. That's focus on symptom management, which,
right,
yeah,
right.
changes can change everything and does change everything.
I think even if you're a clinician and I'm not, so I'm gonna open this up and hand it off to you and hopefully hope it goes in the right direction. But I think if you look at things like, let's say, diabetes,
Hmm.
right? We have
Hmm.
learned when someone's diagnosed with diabetes, in a good medical center, there's lots of supportive services, right? There's taking dietary classes, exercise, all this additional stuff that says you've got this now. It's a life-limiting illness, and
Hmm.
here's all this other stuff not provided by physicians that goes into that. I would argue that that is another version of palliation,
Hmm.
so it's just yeah, it's just
Anything that
it's
raises
quality of
quality of
life.
life and helps that and it's just so wild when you start reading about the chronic illnesses and people are living for so long and how diet, lifestyle, education can control them, reverse them, increase the quality of life. And it's just like, where is the health and where is the care in our healthcare system today that can be life changing.
Yeah.
So, for me, moving into the future with this demographic of elderly and how we're working, palliative care and just symptom management is vital. It's vital. Whether it's done through a palliative care physician, which would be wonderful, but I don't think we have enough in matching the need. But also, what about ourselves and our family and taking that on ourselves to get some education and to implement some of these changes? Yeah.
Right. One of the sort of adages that I've incorporated that helps look at the difference is all hospice is palliative,
Hmm.
but all palliative care is not
Hmm.
hospice. And I
Yeah.
think that helps show the difference. Yeah.
So when we have doctors that are in the system preventing them families from going on hospice because or even to palliative care because they think it's, I mean, I could go through this. I've had patients tell me that they've begged their doctor to go on hospice. That's probably another podcast, but there's a real thing here, and that alludes to the failure we attach to doctors when their patient dies. But, not even referring to palliative care because you don't fully understand that that's not hospice, that's not end of life. Just like you said, how can we fix this? How can we get to doctors and to medical students and medical providers to educate them properly on what palliative care means and also how to support people as they need symptom management and end of life support?
Well, I have several ideas. One of them I think is a recognition that one of the things all of our healthcare professionals report suffering from these days is moral injury or moral distress. And there's lots of obvious out of our control things that are contributing to that, right? Prior authorizations and loss of autonomy and big system and venture capitalism coming into healthcare and all that sort of stuff. What we do have control over, which I think has been contributing to moral injury in healthcare for a long, long time, is facing the fact that at the end of life comes death, and therefore looking critically, looking at, as you say, quality of life, and are these additional services and treatment, so-called treatments, really contributing to the quality of life that the patient has stated they want or hasn't been given an opportunity to state that they want. Yet, folks that are in the healthcare profession are smart people, right? You can't
Mhm.
get into that profession if you're not smart. So you know what's coming and you know what's futile. And that's I think a big contributor to moral distress. So I think if both systems and individuals would take a look at that more in depth and think about what they can do to change that, that would be huge. I'm a I have this big idea that every single med student, PGY, nursing student, allied health student, as part of their orientation to their program, should absolutely be doing their advanced healthcare directives. Why every employee of a major medical center or a hospital does not have their documented advanced healthcare directives is astounding to me. And if I ever do another interim CEO role, that practice will have to know ahead of time that that would be one of the things I would want to see happen in that practice. Uh, so, so yes, I think because doing those, even when you're
Yeah.
perfectly healthy, is a
Yeah.
powerful learning experience.
Supposed to do when you're healthy.
Right, right, absolutely. Supposed to
Mhm.
do it when you're healthy. It's so much better when you do it when you're healthy because when someone does get sick, you have it as a touchstone. So much easier to do in the abstract. You can always change your mind.
Mhm.
But doing it is so enlightening
Mhm.
that then as you were to go forward in your education and then career, you would have such a better understanding of what some of your patients and families are going through, because you could imagine how much harder it is to do those sorts of things when someone you love is ill.
Yeah.
So I would love to see. I think I know there's a couple that I know Loyola. I did a keynote at Loyola Med School in Chicago a couple months ago, and a fourth year came up to me and said she had gotten a grant and had 15 med students that were doing their advance directives. So I'm eager to see kind of what the follow-up on that is and how it went and how it plays out. I just think, you know, the
It
medical,
just allows them to have more
right,
compassion and step into that space because these are quite hard questions, and
right.
there's nothing like walking through the shoes. Talk
That-
about moral injury for a minute. I
Yep.
remember when I was on the oncology unit, they're the 12-hour shifts that are, by the way, never really 12 hours, they're like 14, 15. But
Right.
every time, I know, right? Every time I walked to my car at the end of that shift, I had half of my lunch, if not more, with me. And I always, always felt I didn't do enough. Horrendous. Like running in and out of
And
rooms.
probably a UTI,
For me, well, okay. Yeah, I see
right?
where,
Like nurses
yes. Well,
never get to
I
go.
definitely didn't use the ladies' room as much as I needed to, that's for sure. But yes,
Right.
but horrendous, right?
Yeah.
That is absurd to be saying that that's how you felt, so defeated. And that's what we're up against with our medical practitioners. They're given 15-minute visits. They're walking in with their computers. How do you expect a doctor to tell a patient and family that they have a terminal diagnosis and give them options and explore it and give them that presence and time and let them be in this moment with 15 minutes? I mean,
Well,
there's multiple reasons why we skirt the issue. It's just it's set up not well.
however, it's funny that you bring that up because I have spent the day working on the topic of CPT codes 99497 and 99498, right? Which are the advanced care planning CPT codes.
Okay.
Two codes. The first one is if you talk for 16 minutes or more, up to 30, about advanced care plan. And then the second code, the 98, is the additional 30 minutes, right? So, and together they total 2.90 work RVUs, which is more than a 99204, a level 4 new patient visit. So if you spent over 30 minutes on this. Now, going back to your example, doesn't quite, in the inpatient setting, that has to be done by a physician. In the outpatient setting, that can be done incident to by a licensed clinical social worker. So an oncology practice, and I did a little pro forma on this to, what it would cost to hire a licensed clinical social worker and,
Yeah, this is
have a
promising.
physician oversee their
Yeah,
conversations and documentation. That's necessary. It's got to be
of course.
legal,
Okay.
but it can totally be done and it can totally pay for itself and then some. So
Okay.
I would say back it up and start these conversations earlier.
Yeah. So a couple things. Let's clarify for our listeners. The codes, first of all, I felt like we were in a Mission Impossible episode, which I really
Sorry.
like, by the way. I was like, code, da 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 da. But these are reimbursable codes. Is that what you're
Yes.
talking about? Okay. So it's that people know that how doctors get reimbursed. And I love the fact that you're saying, okay, so code, blah, 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 blah. And it's okay because we don't need to know the code, that you can add on 30 minutes in this. And so you can get a bank of time there.
Yeah.
What I'm sharing from my side of being in the medical system is what doctor even has the availability in their schedule. I love that you brought up, hey, let's hire a social worker and have the doctor oversee because systems need to be in place. These doctors are running from patient to patient to patient because of their caseloads. They, even if they were reimbursed for it, it almost doesn't allow for even that kind of time. And it's heartbreaking within the hospital system.
Yes.
Yeah.
Within
So
within the inpatient setting, it is a real issue.
but
Um,
let's go back to, I think, what the answer could be and what I think we're talking about and focusing on. Let's think about this now.
yeah.
Let's think about it now for myself, for my family, for my loved ones, because that's where the lift is, right? So first it's the wait a minute, this journey is going to change. Yep, it's going to change. What do I want that to look like? I love when you said, hey, if you don't want to talk about what makes a good death, look at the bad ones and say, what do I not want to follow suit with that? Because by the way, if you don't choose, the choices will be made for you, and they're usually what you do not want.
Exactly.
And so I had an idea that, when we go to our annuals, if we are diligent enough to go to them, and I'm not calling anyone out here in this room, um, I thought it would be something so beautiful that maybe at age 50, when you're at your annual, your doctor would just step into the space that they would say, hey, at one point working together in this journey, it's going to change from trying to reverse symptoms or disease processes, and it's going to be focused on quality of life. And then every time I go for that annual, I'm reminded of that. And then when the time comes where they say, you know, we talked about that on the, we're there. So let's really, what is really important to you? We've talked about, you know, how comfortable you want to be in. And I'm feeling good that somebody is seeing me, but not taking my life away, but adding to it in this phase. So we've
Right.
kind of planted those seeds all along. And I think that's a really beautiful way that we can even just open up the seed planting that, oh, one day this journey will not. And I don't have to do everything to run in the opposite direction of it. That's where we're getting into a lot of trouble with a lot of patients and families and moral injury and the whole thing when we're not embracing the natural part of the journey and making it the best it can be.
I absolutely think you're right. I'm not entirely sure we have to wait till we're 50. It all depends on, what our
I'm
circumstances
game. Let's
are.
go
But
for it. Because
yeah,
yeah, well, no,
yeah, but
it's
but
true.
but I totally agree. And I don't want to go back to Mission Impossible, but that's a totally billable event in the office. Um,
So let's talk about that a little bit more. Let's talk about progressive ways forward because what we have now is not working. So talk to me about what you think can happen here that we can have more quality of time with practitioners at the bedside and make this happen. This, especially this conversation when it first comes about.
Right. So as I pointed out, and as your example was at your annual exam, which I assume is an outpatient setting, and
Mhm.
wanting to have that conversation start when you're about 50 and you're healthy and all that sort of stuff.
Mhm.
That is certainly a billable event by a physician or by a licensed clinical social worker. It is billable at the bedside in the inpatient setting, but it has to be done by a physician, and so it is more time. But I would argue. I also, these codes were invented or created in 2016. The underutilization of them has been astounding.
Why do you think that is?
I don't know. It's because I don't think they're having the conversations. I don't think they looked into what I looked into today and wrote up the pro forma on, which is it can be done, and it can be done so that it pays for itself and potentially even make some money in the office setting. I don't even and I wasn't able to get any data on how much palliative care is using these codes in the inpatient setting. But I don't know that detail, but that would certainly be if you know, Bob used to say that especially in oncology, that he believed, and I believe this too, having worked with physicians for about 1,000 years, that one of the reasons that specialists do not refer to palliative care or bring in palliative care as a consultative service is because they either think erroneously that it's the same as hospice, or they think they're doing it. They think they've already covered that. They've already covered symptom management. They've already covered psychosocial. They've covered, some of the, quite frankly, socioeconomic stuff that come into the family unit. And I would just submit that with palliative care being an interdisciplinary team of 4 to 5, depending on
Mhm.
whether there's a
Mhm.
clinical pharmacist involved, it would be impossible, right, for a busy oncologist or neurologist to do all that they're doing in their
Mhm.
limited amount of time and provide the level and depth of of an interdisciplinary team of 4 to 5. So why wouldn't you just get that extra help for you and for the patient and their family?
Absolutely. I mean,
I
there's
think
nothing
that's
like a
another way forward.
nothing, yeah, there's nothing like a fresh set of eyes on something as well, right? And
Yeah.
I think that people they fall through the cracks all the time. They're prescribed different medications from different specialists and different doctors and interactions and things. It's just very messy and it's very easy for each person to show up and just do their part, but not look at the whole person.
Yes.
And we really need to look at the whole person because we're holistic beings. So I love it. I think, you have really contributed and continue to think outside the box to try and help, us move forward in a positive way. So if there's one or two things you could tell a family member, let's focus on the caregiver today. What would you advise them to take into their own hands right at this moment that they can do for caring for their loved ones?
Well, I kind of go back to this most recent book that I wrote, Care Boss, and the leadership approach to caregiving. And in the first section, I talk about mission and vision, right? You can't be a leader without knowing what your purpose is, which is mission, and where you're headed, which is vision. Um, and I would encourage people to, and I do in the book, to create what's your mission statement? What do you do? What's your purpose, your raison d'être? And where is it all headed? Um, I happen to think that it's headed to, right, dignified, peaceful end of life for your loved one, a smooth transition from caregiver to griever, and then a life, right, afterward, your own full life that you go on and have after your care recipient has died. So if I had one thing to give family caregivers, I would say, embrace the leadership role,
Mhm.
identify mission and vision, and do within your power to go forward toward that successful mission and vision.
Yeah, and I love that. And then, I mean, that would be, get the resources, get the education, because there's lots of it out there for you.
Yes.
You're not alone. And I love the follow up because we find a lot of caregivers, their whole life is consumed with caregiving for years and years sometimes. And then they have the end of life. They don't even know who they are anymore on the other side of that. So even
Oh,
just
yeah.
recognizing that that will be a transitional period for you, even just knowing that that's coming, I think is another seed that needs to be planted and helpful, which you just shared. So, Jennifer, great work. Thank you so
Thank
much.
you.
Thank you
Thank
so
you
much for
so
what you're
much.
doing. And thank you for the conversation. And how can people get in touch with you and follow up with you?
My website is Jennifer A. O'Brien, Obrien, like your name, .com. And you can connect with me there. Yeah, I'd love it if you'd visit the website. I also have lots of free resources on the website. So check it out
Perfect.
and contact me if you want.
All right, that sounds great. And we'll put your links below so you can just check in the show
Wonderful.
notes, everyone. And so, again, Jennifer, thank you so much for being on this episode of the Good Death Podcast, Ask a Death Doula. And thank you for the work that you do.
My pleasure. Thank you for the work that you're doing,
Thank
Suzanne.
you very much. All right, everyone. Thank you for being here, and we'll see you in the next episode. Bye, everybody. Okay, there you have it, the Good Death Podcast. And we talk about moral injury with Jennifer O'Brien. We talked about how social workers and registered nurses in the United States can get reimbursed from insurance for doing the end of life care conversations, advanced care planning, reimbursable. That is so exciting. So, yes, RNs can do it, social workers can do it. The doctors don't have the time to do it. So if you want to step into this space, if you are an RN or a social worker and you are wanting to know how you can make a difference and have it reimbursed by insurance, this is your way. This is such an exciting moment. We have a good death movement happening. Join us today. Be part of it. You can be part of it as a professional collaborator. You can be part of it as an individual collaborator because it takes all of us. And think about it. If each and every one of us invited two people to take the free end of life doula training or to join in the Good Death Book Club, think about all of the ripple effect that that would be. So I'm inviting you to be a part of this because the only way we change the world is by doing it together. So click the link below, join the Good Death Book Club, join the Good Death movement. Thank you so much for being here in this episode of the Good Death Podcast, and I'll see you in the next one.